He is a very senior urologist practicing in South Delhi for almost 20 years, and he has a special interest in andrology. We have all heard him many times on infertility or erectile dysfunction. This is a special interest, and I think many of us have sent our patients to him, and they are very satisfied with his expertise. So, very long accomplishments. So, but just recent accomplishments I will mention here. He is a national faculty for training andrologists and urologists at 4-day urology workshop at Nadiad, and he is a member of a special interest group in male infertility of ISAR, international faculty for andrology workshop on sexual dysfunction at Pain Conference, GP Koirala Medical College, Nepal, faculty for many international conferences on particularly male infertility and erectile dysfunction. So I will invite Dr. Vineet Malhotra. Please welcome him. He will talk on erectile dysfunction. Dr. Vineet Malhotra, please.
Thank all of you for taking time out today and coming to hear me again on erectile dysfunction. Unfortunately, I don't seem to be going out of that domain, but what I'll try to do is that today I'm trying to keep it slightly different because there are certain new approaches, and the idea was to talk about them. They may or may not be the ones that will hold the sport in the future, but I wanted to discuss them because you'll be hearing a lot about them, and it's wise to know what we know in terms of information, current data, current literature for these novel therapies for erectile dysfunction. Medical therapy currently in the country available is sildenafil or tadalafil. Sildenafil is also available, but it's too expensive, and I don't like to mention it because we've not found a significant benefit of using sildenafil over sildenafil and tadalafil. Shortly, vardenafil will also become available, which is again a PDE5 inhibitor, very similar to sildenafil, with mild variation in its onset of action and duration of action. And the thing that we found about PDE5 inhibitors is different people will respond differently to these PDE5 inhibitors. So the advantage of having another one is that we will be able to have another PDE5 inhibitor in the basket, and there will be some men who will respond better to vardenafil than they will to sildenafil or tadalafil. So expect this new agent to become available in the next month or couple of months. We've already finished the phase 4 post-clinical trials, and it's in the pipeline with several companies now to become available shortly. It's been available in the international market as Levitra for many years. Unfortunately, it was not available in India, but will become available now. For injectable therapy, again, we've had prostadil, or we make biomix or trimix for quite some time now with papaverine and chlorpromazine, or trimix where we add prostaglandin to it, and it is an extremely effective therapy, though a lot of patients are reluctant to first hear or accept the fact that they will have to inject themselves into the penis. But once you've got that fear out of their minds, and once you've demonstrated it to them, once you've asked them to demonstrate injecting themselves in front of you, a lot of our patients then actually are very comfortable with. The erection hardness score with a injectable vasoactive drug is very good. And a lot of men, especially with unconsummated marriages, younger men, high stress levels, unlikely to respond to oral therapy, are very good initially with the injectable therapy. So men that have not responded, and you're looking at these men, troubled marriages, early unconsummated marriage, very good response to this intracavernosal vasoactive drug, and they do very well, and then you can shift them back to medical therapy, and they do well. Vacuum devices, I personally don't use vacuum devices for erectile dysfunction treatment per se, because they're very cumbersome to use. Most men are unhappy using it as a primary device for ED. though a lot of men will be put on the vacuum device when they are having rehabilitation, which means they are recovering from surgery, or they've had a failed implant surgery and have to have a second implant procedure and need to have the regain for length. So a lot of these men will do, or they have peronees which has resulted in scarring, fibrosis and shortening, and you're going to then use the vacuum device to rehabilitate these patients. And finally, penile implant therapy. I think we've had a talk on penile implant in this forum before, and sufficient to know that this is the curative treatment for erectile dysfunction and has greater than 95% satisfaction rate. So of all the therapies that are used to treat erectile dysfunction, penile prosthesis surgery is the one with the highest patient and partner satisfaction rate, especially the inflatable penile prosthesis surgeries. There are certain things which have become common now, and we will be discussing two of these today. I am not dwelling on regenerative therapy because one, I don't have enough data for this, and I don't have currently too much belief in this form of therapy, and that can change because it's changed for low intensity shockwave therapy after we've modified selection of patients and after we've come to a small group that we can treat. So that can also change. I never say never, because you must have an open mind and you must accept any therapy with open hands that has been prescribed. It's the only thing that we should test each therapy scientifically and then form our opinions. With regenerative therapy, at least I am not there yet, and when I do accept it, I will very happily present data and talk about it. Today we are going to talk about daily dose medication, which means medical therapy which is used in a daily dose format, and low intensity shockwave therapy. We know how PD5 work, but very quickly. So you have release of nitric oxide from the non-adrenergic, non-cholinergic receptors or the endothelial cells, which activate guanylate cyclase, converting GTP to cyclic GMP, causing flux of intracellular calcium, relaxation of the smooth muscle, and penile erection. When this breaks down to GMP, this is facilitated by the enzyme phosphodiesterase type 5, and this is the step which is actually inhibited by PD5 inhibitors that we use. So that's the physiology or the pharmacology of how PD5 inhibitors work. And the rationale to use therapy which is continuous is based on this. So during erection, oxygen tension changes in the corpus cavernosum from 30 to 40 in the flaccid state to 70 to 100 millimeters of mercury in the erect state. So if it is flaccid, you have increased TGF-1 secretion, more collagen production, more fibrosis and venous leak. With more pressure of oxygen tension, you have increased PGE secretion, which results in a reduced collagen production and preserved erectile tissue integrity. So we also say, there's a phrase that we use which is said, use it or lose it, which indicates that the more you use an erection, or rather more that you keep the oxygen tension elevated, the less likely you will allow TGF-1, that's the transforming growth factor 1, to actually accumulate in the cavernosal tissue, the less likely that you will have fibrosis and collagen production, and hence less likely that you will have venous leak. This is particularly important in post-surgery, post-radical prostatectomy patients who are having severe vasculogenic disease which does not allow them to get frequent erections, and hence will perpetuate the loss of erectile function. So actually, erectile dysfunction is a disease which has a vicious cycle to it. The less you have an erect state, even more less likely you are to get a subsequent erection. And that's the entire rationale behind rehabilitating these penises. Yeah. So there have been various studies which have actually tried to assess using on-demand versus continuous therapy, and Padmanathan was amongst the first ones that actually studied this. And most of these studies were actually performed, rats have been our very good friends. So a lot of these were experimental studies which were performed in rats, and the human studies have been performed in men that have undergone radical prostatectomy. Ideally, non-nerve sparing radical prostatectomy, but we found very high rates of erectile dysfunction even after nerve sparing radical prostatectomy, and they formed good index cases for studying this. So these were patients that actually underwent radical prostatectomy who had evaluation preoperatively. The start of drug after the recovery period of 4 weeks, post-drug treatment 36 weeks, and a drug-free post-operative assessment period where they ended drug at 36 weeks. So both Padmanathan, when he used sildenafil 50 milligrams or 100 milligrams nightly for 36 weeks versus Montorsi that used tadalafil 5 milligrams daily, found significant treatment effects versus the use of placebo, and essentially not only in preserving the erectile function but also in preventing penile length loss. And we'll talk about some of the clinical uses that become relevant when we talk of using such agents. So may be used for erectile dysfunction with or without lower urinary tract symptoms. We'll talk about when you will use it for erectile dysfunction and when you will use it with lubes. For penile rehabilitation, adjunctive therapy with newer modalities such as low intensity shockwave therapy. So now, before I move on to low intensity shockwave therapy, some of the important points. In fact, these are questions that have been asked to me quite frequently ever since this usage of 5 milligrams of tadalafil has become popular. Is it effective as a single drug for men with erectile dysfunction? For men with psychogenic, which means young men with psychogenic erectile dysfunction, this is a useful drug. And why is it a useful drug? Because it results in spontaneous erections even in men who do not have an underlying organic disease. So if you have a young man who's come in with psychogenic erectile dysfunction, he has no organic disease, this is a good drug to use. He's going to get more spontaneous erections, the fullness in his penis will be more prominent, and his negative psychogenic effect will likely wear away. So useful in this young man for treating his erectile dysfunction, which in any case was never an organic erectile dysfunction. Is it useful for men who have organic erectile dysfunction? Not as a primary single therapy. 5 milligram dose is a highly inadequate dose to be used for treating erectile dysfunction of organic disease. Therefore, if you are treating a man with organic disease for erectile dysfunction, you will have to use a higher dose of either tadalafil, sildenafil, or whatever drug you wish to use. But the 5 milligram dose alone will not be useful. There, it will or is now being used as an adjunct to the newer therapies such as low intensity shockwave therapy, and you may use it as an adjunct to other therapy. If there is an older man with lower urinary tract symptoms and you intend to use 5 milligrams of tadalafil, it has several advantages. Again, one of the most significant advantages, a lot of these men will come in telling one complaint: I feel my penis has shrunk and shriveled in size. And this 5 milligram tadalafil is very useful because it's actually going to allow the penis to appear bulkier, because as I mentioned, it's actually reversing the effect of that fibrosis. So for these men, it's very important for them to get their confidence that the penis is not shrinking, shriveling, and will not disappear one day. but it will not give an erection enough for satisfactory sexual intercourse. So what do you do then? In these men, you're going to prescribe 5 milligrams of tadalafil for their lower urinary tract symptoms and this beneficial effect for giving a mild spontaneous erection, fullness of the penis, and advise an SOS PD5 inhibitor on the day that they have sexual intercourse. Now, a lot of these older men will have very infrequent intercourse, which means once in 15 days, once in 10 days, once in a month. And so giving sildenafil 100 milligrams on that day that they intend to have intercourse is a very useful suggestion. So in these men, the treatment protocol would be 5 milligrams of tadalafil daily, which will cover for their lower urinary tract symptoms and their effect for that shrinking shriveled penis, and a SOS PD5 on the day that they require a hard erection for penetrative intercourse. So that's how this 5 milligram tadalafil may be used. When using single medication, a higher dose of tadalafil, 10 or 20 milligrams, or sildenafil is far more effective than using 5 milligram nightly of tadalafil alone. 5 milligram SOS of tadalafil is of no use in men with organic PD. So that's the message that has to go out when treating erectile dysfunction with 5 milligrams of tadalafil. Now coming into the next newer form of therapy that you hear a lot about, which is low intensity shockwave therapy. This has been a boon and a bane because of the fact that it is very easily available. Practically anyone can do it. So you have technicians all over the place who are giving low intensity shockwave therapy. The problem with that is unselected patients underwent low intensity shockwave therapy in an inappropriate way, and it got a very bad name. So a lot of patients ended up getting extremely dissatisfied and coming back to us saying we've spent so much money in treatment by low intensity shockwave therapy, which was a total waste. So is it a total waste? Actually, this is what we are going to question and try to find out. So shockwave therapy has been used for very, very long. In fact, the first use of shockwave therapy was in the early 80s, or in India in the late 80s actually, where lithotripsy became common to treat stone disease, orthopedics for inflammatory disease, and erectile dysfunction. Now, in the last 4 to 5 years, shock waves carry energy which propagate through a medium. It's a sequence of single sonic pulses, fast pressure rise, fall. There's a very short life cycle to this, and that allows this wave to cause a bubble to be created, which actually creates the essential break either for the stone or the minimum shear that we are going to cause in terms of the mimicking of a endothelial injury in the corpora of the penis. So tissue is first compressed due to positive pressure, then expands, cavitation and a shear stress on the endothelial membranes. And these induce angiogenesis, essentially new blood vessels. So this is the theory. When we give a low intensity shock wave, it's going to mimic a mini injury shearing injury, which will allow sprouting of new blood vessels, and the endothelial cells will be involved in creating these blood vessels and capillaries. So this is essentially a mechanism of, so if you start from here, you have the angiogenic factor production, release, endothelial cell receptor binding, activation, proliferation, directional migration, remodeling, essentially finally ending up with new blood vessel formation. There have been a lot of studies, and these are indicated that you've actually been able to, in animal models, these are rat models. In a lot of these studies, what they actually did was they tied they injured the cavernous nerves in the rats, and then gave them shock waves, and then did angiographic studies to see whether there was any benefit of that, and they found that there was significant neovascularization after low intensity shock wave. And these have also changed. You've had shock waves which have been used to treat myocardial infarction or myocardial disease, and you've had different types of shock waves. You've been using them for inflammatory disease in bones, tendons. You've seen that there's been a real increase in the production of eNOS after application of as little as 500 shock waves maintained for several weeks. Again, pre-treatment you see much less vessels, and post-treatment day 28, as early as day 28 you see a significant number of collateral vessels that may have developed. This is how a shock wave is actually given in a rat. So again, there's a lot of data which has shown real sinusoidal endothelium regeneration, arterial endothelial regeneration, smooth muscle regeneration, and is this data actually transposable to humans? Are we able to actually prove this development of collaterals in humans also? We are actually, so they've seen this in coronary collaterals, they've seen from the control group, the group that received shock waves, developed collaterals as early as 4 weeks, 28 days post-therapy, improved LV ejection fraction, stroke volume, and significant amelioration of chest pain even after a 6-minute walk. So essentially, even in non-ED case scenarios, there's been a lot of data which has shown low intensity shock wave to have caused significant changes. We'll come to our topic, which is erectile dysfunction. And again, there is data. So penile low intensity shock wave therapy is able to shift, and this is actually a very important group. This is a group of patients that are non-PD5 responders, in whom after using low intensity shock wave therapy, they became PD5 responders. This actually also defines the group of men that we are going to use this low intensity shock wave therapy in. These are obviously men with organic disease. They are men who have not responded to PD5 inhibitors, or even men who previously responded to PD5 inhibitors and then became non-responders to PD5 inhibitors, and reversed or returned back to responding to PD5 inhibitors after receiving shockwave therapy. In our study, in the data that we are collecting, this is an important group of patients. The erection hardness score has increased significantly in men that received low intensity shockwave therapy, and even in men who first did not respond to sham therapy and then went to low intensity shockwave therapy, there was significant benefit. So again, if you have the right group of patients, which is mild, moderate, severe vasculogenic disease for erectile dysfunction, especially the moderate to severe vasculogenic disease, there are men who will, or a percentage of men who will respond to low intensity shockwave therapy. And there's been a lot of meta-analysis which has been studied, again, which shows the number of shocks, which means you ideally would give between 600 to 3000 shocks in one sitting, and up to a total of 6000 shocks over 3 to 6 sittings. We'll come to the cycles or the regimens that we use. The guidelines now say, the EAU guidelines now say that it could significantly improve IIEF and erection hardness score of ED patients. So what are the indications where we will use low intensity shockwave therapy? As initial therapy before initiating drug therapy for prevention. Now, this is a very questionable use. In fact, we found a lot of patients not responding to prevention as a mode of treatment for low intensity shockwave therapy. As replacement for patients on PDE5 therapy, yes, we found men who had the use of higher dose of PDE5 inhibitors revert to either a lower dose or go off PDE5 inhibitors with use of low intensity shockwave therapy in patients where there is contraindication to use of PDE5 inhibitors. This is actually an indication because here you cannot use PDE5 inhibitors and these patients would either end up with injectable therapy or implant surgery. We've already spoken about the data that's available for non-responders, and in patients that require rehabilitation, this is useful. Some of the, so it is efficacious, we've seen the data. Very important, no adverse effects, no side effects. The long-term efficacy has been studied now up to a period of 2 years. Beyond 2 years, we really don't have too much data. And it's said that you may require a repeat cycle therapy after 2 years to keep the efficacy of the therapy. It's possible to recover from severe ED, especially in patients who have now turned non-responders, and it may allow eliminating the use of medication. So when we are looking at, a lot of patients come to me asking me, can you get me off medication? I do not want to use medication for treating my erectile dysfunction. This is a possible therapy for these men for getting them off the use of medication for erectile dysfunction. What kind of machines? This is another very crucial question because you hear so much about it, and this is a gray area because the data here is mixed. You have a lot of machines which are available. I do not subscribe or advise or market any of them. Broadly, what I'll tell you is that this discussion is about the benefits of linear versus focused therapy, which means you can either have a inducer which is probe which is linear and broad, or one which is pointed and focused and gives, like for stones, a focal point therapy. And we still need more data to understand which is more effective. Each of them profess that they are more advantageous. There's a lot of question mark about how many shocks do you give in one session, how many do you give to the crura or the corpora, what are the total number of shocks, what is the schedule of treatment, frequency, additional treatment, repeated treatment. Broadly, currently, you may use any of these. What we use is twice a week therapy. We give 3,000 shocks in one sitting. We give 6 total sittings, which means we are using 18,000 shocks. We did a study with 50 patients free of cost before we embarked onto using low intensity shockwave therapy, just to understand what was the correct treatment regimen, selection of patients before we even started this for any patient. And what we've deduced from that is that the intensity need not be as low as is being prescribed. Now, a lot of these companies are going to talk about 0.1 millijoule of energy to be used for these men, and there are very few machines which use between 0.09 and 0.1 millijoules. It's the far more expensive machines which actually are able to bring the shockwave intensity onto that zone. When we did 25 patients with 0.09 millijoules of intensity, only one of them responded. We changed to a machine which was 1/10 in cost and used between 1 to 5 millijoules, practically 10 times the intensity of what the previous machines. We've had a 50% response rate. So instead of actually lowering the intensity, we upped the intensity a little bit. We increased the number of shock waves. Now, most studies talked about using a total of 6,000 shocks over 6 cycles. We increased it to 18,000 shocks, and again found the response rate increasing to 50%. The broad idea was to select the patients correctly. If you are going to treat men with psychogenic erectile dysfunction with low intensity shockwave therapy, you are going to have a very, very high failure rate. If you have an unselected patient group, you are going to have a very high failure rate. So your patient selection criteria must be good. We are not giving any therapy by technician, which means all therapy is imparted only by me, because I will select the number of waves that are given to the crura, to the crust, to the organ shaft and to the areas on the shaft. So we found these to make a significant difference in the response rates to the patient. So by doing that, we found our own protocol. Is there an international protocol available? No, unfortunately, these are still areas of further research. We need to have more successful results. We need to have the effect lasting longer. We must have something for the unsuccessful patients. We must have patients who previously had a successful response and now lost it. But essentially, this is something that we are still evolving in terms of treatment. A slight mention, because we're talking about novel therapies, so there is a mention about PRP, bone marrow derived progenitor cells, and adipose derived. I don't use them, so I will not comment about these. You will hear a lot. I think there's going to be a lot of this in the coming years. My concern is only one. My concern is everyone who uses this must use it for his specialty of knowledge. We find orthopedicians treating disease of diabetes, and we find plastic surgeons treating erectile dysfunction or fertility failures. It's not ethical, it's not right. We understand our area of expertise. We must focus on our area of expertise to understand the mechanisms of the disease to be able to treat them. In a fertility conference, I was told by a leading fertility expert how she used testicular stem cells to treat azoospermia in a man, and my question was, where did you inject them? And she said, under the scrotal skin. And I don't know cells, not the patients. So our understanding of any mechanism, which is what holds me from using therapy, our understanding of any therapy basically arises from our expertise in understanding the disease first, and that must be our basic criteria to use these therapies. I'm not saying that they will not become useful. It's possible that they will become the therapies of the future, but my concern is that it's probably more abused than used, and we will see a time when it becomes more regulated. We will see a time when specialists, as in other cases, I can't do a hip replacement surgery and I cannot do a cesarean section, however well I may know how to do it. Similarly, I would be treating my area of expertise only. But you'll hear a lot more about this in the coming years. I like to talk about this in the end because this is something that we do very well, is treating men with erectile dysfunction with surgery, and we can treat them with either of these therapies. So if everything else fails, this is a foolproof kind of therapy which has very high satisfaction rates. You will have newer modalities in this also, and this is being currently studied in a Institute of Research, Institute of Urology, London, and they are studying this thermal penile implant, which actually changes its state on the basis of state of temperature change. But currently they are requiring very high temperatures to actually change that state. So it is into a gel state and then changes to a solid state when the temperature lowers. But to put it back to gel state, you require very, very high temperatures, and that's the challenge they are facing right now. We are also coming up with newer electronic controlled penile implants, because currently the problem with penile implants is that the pump mechanism is a little cumbersome, and that might change to a more Bluetooth or a mobile controlled kind of a device. The challenge there is that the volume of fluid which is required to shift from the reservoir to the implant is too large for a small electrode to move. So we're in the process of actually, I'm part of that research committee where we're trying to develop a electrode which is small enough to allow 50 to 75 ml of fluid shift by electronic signals. That's something that you will hear in the future also. Thank you for your kind attention.
I was particularly impressed about low intensity shockwave therapy and daily dose of, I think, tadalafil. So daily dose of tadalafil, how long? If a young patient, you said in 2 age groups it can be given. In older age group, will loops, it has a special advantage in younger age group. So how long a young patient will take it? For years?
So this is a brilliant question because this is going to happen in everyday practice. Now, as I mentioned, the young patients are those that have psychogenic disease, not organic disease. And here the purpose of the drug is actually to try to get them rid of their psychogenic disease. A lot of times I will use anti-anxiety medication along with this, and SOS, as I mentioned, this is not good enough to give an erection hardness for penetration. So SOS PD5 inhibitor in full dose on the days that they will attempt erection. The idea of using daily dose is only to get the psychogenic effect away. Usually we will limit this to a maximum of 3-month dosage, but we'll follow them on a monthly basis, which means we will usually give a first dose for about 3 to 4 weeks and see if they've gotten off it or not. Most of the times you do not need to give it beyond 3 months, but you can use it for long term without side effects.
And lower intensity shockwave therapy, is it the same shockwave which you are giving for lithotripsy?
That is much more higher intensity.
No, intensity is different, but
Absolutely.
same shockwave.
So currently there are 3 forms of machines which are available. You may have electro-hydraulic shock waves, piezoelectric shock waves, or electromagnetic shock waves. And all 3 are used, have been used for stone, all 3 have been used for erectile dysfunction also.
So this is very interesting. I think low shockwave, low intensity shockwave therapy, and you have showed many trials in I think animal. So any personal experience, clinical experience?
I think I mentioned. So we actually divided our clinical experience in 2 groups. One was the early group of unselected patients with a very high quality machine, extremely expensive machine, and then the second trial where we used a higher intensity, lower cost machine where we tried to make it a more effective therapy with very selected group of patients. In the unselected group, we had very high failure rate, miserable. I was absolutely unhappy with this. We had done it free of cost for the patients, and out of 50 patients that we treated, only 1 of them showed some response. Totally disappointed, we just gave it up. I thought of not using low intensity shockwave therapy. Again, because of the data which we received, I discussed with a lot of institutes in the US which were very to use it, especially Ranjit Ramasamy, and they talked about selecting patients far more narrowly and then using it. So we then narrowed our criteria and then started selecting the patients far more, I would say, judiciously, and eventually started seeing a greater than 50% response rate. I don't like to actually profess about anything which is very short term, because we're actually seeing better response than that. But with this, our experience is less than 8 months now. So I don't want to comment about the total outcomes, but we've had very good results now since we
will have another CME after 6 months.
Thank you, Dr. Vineet. Very interesting talk, sir. Also interestingly, recent studies have confirmed that erectile dysfunction is a predictor for future cardiovascular disease, especially as they probably share the same etiology which is vasculogenic. Also, some studies have said that PD5 inhibitors have no increased risks of CV events. So probably calcium channel blockers like nicotine or amlodipine, because the risk is of hypotension. The risk is of hypotension, nothing else.
But the documented contraindications are nitrates
Definitely.
and alpha blockers.
Alpha blockers,
There is no mention of other antihypertensives.
No. If you give nifedipine or amlodipine, the chances of developing hypertension is there.
It is not on the pamphlet.
So I'll answer the same question. When you use, and so again, let me start from how this controversy or whatever arose. When they used Viagra first in the US, in the first year they had 130 deaths with the use of Viagra, and there were several lawsuits which were put up against Viagra. When they researched them, they found that all of the Viagra deaths which had happened most commonly in men that had also used nitrate, which was a very specific contraindication for the use of PD5 inhibitors. And it used to happen a lot in the emergency department, because with the PD5 inhibitors, the man would develop palpitation, and the emergency team would respond by giving sorbitol or nitrate, and that would result in irreversible hypotension and death. Eventually they found out that there was no direct correlation or injury that was caused by PD5 inhibitor sildenafil to be associating it with cardiovascular risk. So that was taken away altogether. In fact, it was actually researched for cardiovascular disease, for treatment of patients of pulmonary hypertension. The use of calcium channel inhibitors is not a contraindication for the use of PD5 inhibitors. However, as we do with all alpha blockers, we counsel men that they must watch for any periods of dizziness or any evidence which would suggest postural hypotension with the use of these, with the concomitant use of these agents. We do that for all alpha blockers also, and counsel them that if there is such a thing, they would discontinue and contact.
I'd like to interrupt you here. I have a patient who's taking olmesartan as a hypertensive drug. Whenever he takes sildenafil, his blood pressure drops to 80.
So, as I
Talking about nitrates, any kind of antihypertensive drug would reduce in combination.
So again, not all. A lot of men with antihypertensives use PD5 inhibitors regularly without any fall in blood pressure. As alpha blockers also. You know so many men who use alpha blockers and antihypertensives and don't get postural hypertension. So it's important to know that this may happen, but it's not a contraindication per se.
I think it's time to discuss with the cardiologist also.
Okay, so talking about the latest PDE5 inhibitor, the evenafil, probably the shortest acting drug. Half-life is just 3 hours.
So it is professed as the shortest acting drug. Actually, the important thing is not the duration of action, but the onset of action. And unfortunately, it's not very different from sildenafil or vardenafil when we talk about onset of action. Tadalafil has a slightly delayed onset of action, which is why we usually will tell patients to take it about 2 to 3 hours before it, because if they want to use it as an SOS drug. All the others will have a between 20-minute to 40-minute onset of action. So,
efficacy is similar.
Yeah, it has a shorter half-life, but the onset is almost similar to vardenafil or sildenafil. So actually, it's not very different there.
So my last 3 questions. So the alpraprostadil, the prostaglandin E, injections, intraurethral suppositories, and gel properly is now available. How effective is it?
I always use the word muse is only to amuse. Muse was the intraurethral suppository for prostaglandin, which is in the dose of 1000 micrograms versus a 7.5 to 15 microgram of alprostadil in Caberjet, which is the injection that we use for erectile dysfunction. So you can imagine the amount of dose that you require for it to be absorbed from the urethra. So it's an extremely ineffective mechanism. The gels have not proven to be effective. It's only the injectable which works.
You already dwelled about the list. Probably angiogenesis, you said about that, and vascularization. Sir, IPP, the inflatable penile process, is now seen as a gold standard for ED, especially patients refractory to medical therapy. And boasts of 90% of satisfaction.
Very high. And I mentioned patient and partner satisfaction. So both of them very, very high. Which is why this is actually an extremely effective therapy for men who've not responded to other forms of treatment for ED.
So, regarding the implant, the use of 3D printing and new biomaterials like nickel and titanium, probably in the topic.
So, nickel titanium alloys have been used in implants for quite some time, but the ones that you're seeing, the new ones, these are the form changing implants, the nickel titanium thermal implants. So they actually change their form and allow the benefits of an inflatable device without having to use fluid, pump, reservoir, any of them. I don't know how far away we are from them being used eventually, but they are under research right now.
Interesting times, sir.
It's very interesting times.
Sir, I have also got a very small question.
Sir, please.
Actually, in general practice, I am doing in general practice. We are also using the same method. But the one question, very small, that male also comes and female also comes, that I have lost the interest. Female says, vaccine partner says, I have lost the interest. I know the topic was for TD only. But for female, do you suggest something?
I don't treat women for any sexual dysfunction, but Viagra was attempted to be used for women. Huge amount of money was spent on it. Pfizer eventually withdrew it. What it does is it increases the warmth in the genitalia in women also. So we still do use it sometimes for women, though there are other drugs, piperacillin and other drugs which have been used for women for sexual dysfunction and low desire. I don't treat women, so I will actually not want to comment on it further.
Sir, a few questions from my side, sir. It was very, very tough. We will have penile pacemakers. We are proceeding towards that. It will be electronically monitoring and everything. So maybe this becomes a reality. So when do you do a penile Doppler? Indications.
I advise a penile Doppler. In most centers, penile Doppler is either done using oral PD5 inhibitor or papaverine alone. If you do a penile Doppler using these two agents only, you will have an inadequate erectile response, which will give a false impression of venous leakage. These days they even talk about endothelial dysfunction on penile Doppler, which I wonder how it is assessed by a radiologist. But that's what you get a report as. The ideal way to do a penile Doppler is to either use the bimix or a trimix and get a full erectile response, and on that do the penile Doppler, so that you would have then achieved complete rigidity, compression of the subtunical venules, and so you will not erroneously diagnose venous leakage because you had a suboptimal erection. I only do it as a prerequisite to safeguard before documentation before surgery. Otherwise, we do an injection in the clinic and see the response of the patient. It doesn't need a penile Doppler.
So how many
Sir, we got a small incident though.
side effect of Prp if we inject intracavernosa?
Very high incidence when you are using papaverine alone, and much lower if you are using a bimix preparation.
Sir, have you ever come across priapism during therapy?
Plenty of times. So,
how do you treat them?
in fact, priapism happens very, very commonly. And we have what we call uppers and downers, which means upper is the one which causes the erection and downer is the one which takes away the erection. And even my residents know how to take down a priapismic erection very easily. No, the simplest format, if it is early, especially after therapy, we don't allow any patient to leave the clinic that we have injected. He must go without an erection. If we have seen an erection which has lasted for greater than an hour, we inject him with either phenylephrine or adrenaline, and you inject just about 50 micrograms to 100 micrograms and he loses his erection. If he has an erection which is from somewhere else and it is still of less than 4-hour duration, we can still go ahead and do this injection of adrenergic agents and he will still lose the erection. A lot of times these men will come with a longer duration erection. If it is less than 24 hours, then you do use something which is called slow external cavernosal drainage, which means you put in a butterfly needle and allow blood to drain out, which allows the old deoxygenated blood to go and the new oxygenated blood will come in. The new oxygenated blood allows the response of allows the normal cavernosal contraction to happen, and so the penile tumescence goes away. If it is beyond 24 hours, then a lot of times they will require procedures. They are called shunt surgeries. I don't think this is the forum to discuss surgeries, but you have procedures for them also.
There was a mention of PDE5 inhibitors resistance. to reduce that you give that low intensity voltage. So are there any other ways to induce sensitization other than the shockwave? Shockwave is something very specialized.
So
Can something else be done?
currently, this is something which has become available. We used to use penile injections also to sensitize them because it's about, as I mentioned, you have to get more frequent erections. The more frequent the erections, the less likely fibrosis will happen. The problem is that injections into the penis are not acceptable very, very easily. So this is a far simpler method which has become
My
available.
last comment, sir, any foods which improve eating?
Particularly, there are a lot of foods that will hamper ED, though there have been foods which have been advocated for erectile dysfunction, things like avocado, but less of those foods are used in our Indian common diets.
What is avocado?
It's a fruit
Very
kind
good.
of a.
Very fruit.
It's very difficult to eat, so you know we don't even have taste for those kind of. It is available.
Doctor,
Big basket gives everything.
shockwave therapies were banned because they were using these shockwave therapies in homosexuals, and these are now banned all over the world. So what is your take on this? Because if you are using shockwave therapies in India, definitely if a person you are treating with sexual dysfunction or erectile dysfunction, if he will come to you and you had used a shockwave therapy, and if he is not getting his erection proper, he can sue you in the court and you will have a problem.
No, there's a lot of evidence. I've shown you EAU guidelines now. So, shockwave therapy, which was used in the 70s, was very high intensity shockwave therapy. In fact, it didn't start with homosexuals. They started using it for Peyronie's disease. So, the first use of shockwave therapy for any sexual dysfunction began with Peyronie's disease. They thought that the equivalent of stone, and not in the 70s, 80s, because shockwave therapy was invented in Germany at that time. And they started thinking of Peyronie's as stone within the penis and started from there. The only problem was that it was very intense. So, as the question asked by Dr. Kodar, it was very high intensity shockwave therapy. And that had significant damage. So, what it actually did was significant fibrosis and damage to the penis. That obviously is not recommended anywhere. The shockwave therapy, which is now in this process a part of the EAU guidelines, within this thing of the AUA guidelines also is low intensity shockwave therapy. So we must differentiate between shockwave therapy, which came in the 80s as a high intensity shockwave therapy, and the current use of low intensity shockwave therapy, which has a lot of data. I am actually one of the very, very late starters of this, and I have a very select group of patients that I use for this. But there is now a lot of data for low intensity shockwave therapy. It's used and its role in releasing or being a nitric oxide donor, it's slightly more complex there. It's not as effective nitric oxide donor as the PD5 inhibitors. However, it's a gray area. I do use it. So in patients who have low libido and erectile dysfunction, I somehow find a complementary effect of using L-arginine as a nitric oxide donor and a PD5 inhibitor. So I do use it in some patients, but it is question mark. Literature-wise, L-arginine is, especially the AUA and the AU guidelines, do not give much. So it's a weak nitric oxide donor. By itself, L-arginine is not an effective nitric oxide donor alone. If you use it as a single agent, it will never work. As a complementary agent, even I use it because I've seen it to work, especially suppose I have to use a larger dose. I'm using 100 milligrams of sildenafil and it's not working effectively. I will tend to add an L-arginine there because it will not have the side effects of increasing the dose of a PD5 and would still add to some of the nitric oxide donor effects.
Are there any questions from the back?